All right, today we're jumping into a real clinical detective story, how medical teams track down and treat two pretty serious and often hidden conditions, abdominal abscesses and fistulas.
So here's our game plan. We're going to follow the exact path a clinical team would. We'll start by understanding the danger, then we'll look for the signs and suspects, figure out how to crack the case, go through the treatment playbook, and finally, look at the outcomes.
So, first things first, before we can even start looking for the problem, we've got to know exactly what we're dealing with.
Okay, so this is actually way simpler than it sounds. An abscess is a collection of pus. Think of it like a walled-off, angry pocket of infection. A fistula, on the other hand, is a connection. It's an abnormal tunnel that forms between two places in the body that should definitely not be connected. So, super simple. One's a pocket, the other's a pathway.
Okay, now we get to the really interesting part, the actual detective work. To start building a case, we need to look at two things: who's most likely to get these conditions, and what clues are their bodies giving us? You know, the first question any clinician is going to ask is, hey, does this patient even fit the profile? So who's most at risk for developing these problems? And it really boils down to two main things. On one hand, you've got events that physically break down the body's natural barriers. Think recent surgery, some kind of trauma, or an organ like the appendix bursting. Then, on the other hand, you have conditions that just weaken your body's ability to fight back. Things like chronic diseases or drugs that suppress the immune system. Either way, you're basically rolling out the welcome mat for an infection to set up shop.
All right, so let's say we have a patient who fits the risk profile. What are the actual clues a doctor is searching for during an exam? What are those telltale signs?
And these clues, they really fall into two buckets. First, you've got what we call systemic symptoms. These are signs that the entire body is fighting a huge infection. We're talking high, spiking fevers, chills, a heart that's racing. But then you get the more localized clues, and these can be super helpful. For example, if a patient just can't stop hiccuping or they have pain in their shoulder, that could mean an abscess is up high, irritating the diaphragm. Pretty clever, right?
So, we've got our suspicions. The picture is coming together. Now it's time to prove it. This is the diagnostic phase, where we bring out the big guns to get a definitive answer.
And you almost always start with the simplest, least invasive thing first, right? So before you jump to any fancy scans, the team's going to look for clues in the patient's blood.
And what are they looking for? Well, a high white blood cell count. That's basically the body calling in the troops to fight. You might see anemia, because a long-term infection could do that. Sometimes liver enzymes are elevated, which just means the infection is stressing out other organs. But the real smoking gun, a positive blood culture. That's proof. It means bacteria are literally circulating in the bloodstream.
But here's the thing. Blood tests can scream infection at the top of their lungs, but they can't tell you where it is. To find the source, you've got to see inside the body. And that's why imaging is the real key here.
And when it comes to looking for an abdominal abscess, there is one undisputed champion, the CT scan. It is the gold standard. And here's why it's so brilliant. It does two jobs at once. Not only does it give you this incredibly clear picture of where the abscess is and how big it is, but you can also use it to guide a needle right into it. So you can drain it and get a sample to see exactly what bug you're fighting. It's a diagnostic tool and a treatment tool, all in one.
Okay, so the case is cracked. We know what it is, we know where it is. Now the whole game shifts from investigation to action. It's time to open up the treatment playbook. And the plan is really methodical. It's built on three pillars. First, supportive care. You gotta stabilize the patient. Fluids, electrolytes, nutrition. Step 2, and this is the big one, is drainage. You have to get the pus out. Usually that's done with a needle through the skin. And third, you hit them with targeted antibiotics to kill the bacteria. You start with a broad spectrum one, and then once you know exactly what you're fighting, you can get much more specific.
I really want to pause here because this is so important. Supportive care is crucial. Antibiotics are essential, but they won't work on their own. You can't just throw antibiotics at a pocket of pus and hope for the best. The absolute non-negotiable cornerstone of treatment is getting that infected material out of the body. Period.
All right, in our last section, let's look at the aftermath. The treatment started, so what happens next? What are the potential bumps in the road? And what's the general outlook?
And this right here is exactly why you have to treat these things so quickly and so aggressively. If you don't, that infection can spiral out of control and lead to things like multi-organ failure. And even when treatment goes well, there are still risks. The abscess could come back, new fistulae could form, or you could end up with other complications like a bowel obstruction down the line. So after all of this, after looking at who's at risk, the symptoms, the tests, the treatments, it really all boils down to one final question. What's the single most critical factor that decides whether a patient has a good outcome?
And the answer brings us right back to where we were: adequate drainage. It was the most important step in the treatment plan, and it's the most critical factor for recovery. Everything else, it's all in support of this one central action: getting the pus out. That is, and always will be, the cornerstone of recovery.